Thank you very much. Good afternoon to everybody. Well, having heard Marco Ranieri's talk, I was thinking I have really to reconsider my intake of vodka, because if I get so many good ideas while drinking vodka, I have strictly to reconsider it. But anyway, first of all, I want to show you my disclosures, because I think today this is very important that you know that there are some disclosures. And then I would like to focus with you on my topic, and I would like to change a little bit, because many pitfalls in abdominal pressure measurement are related to the methods you are using. I'm talking about methods, pitfalls, and then of interest. So first of all, if we talk about abdominal pressure, you should be aware that abdominal pressure is something that might be rely a little bit to what we are used to if we talk about the brain. But there is a small difference. It's similar to what we know from the brain, that as an increase of the volume leads up to an exponential increase of the pressure. However, you know at the brain there is a skull, and the skull definitively cannot be expanded anymore. And this is a little bit different if we talk about the abdominal cavity. But nevertheless, the pressure-volume relationship behaves more or less in the same way as in the brain or in the skull. And at the very end, you end up that in the beginning, there is a huge capacity of compensation, and all of a sudden, you get a sudden increase of intra-abdominal pressure. And the intra-abdominal pressure today can be measured in many places. Vena cava inferior, we'll go quickly back to that, via uterus, via rectal pressure tip, via direct access to the abdomen, via gaso or oral gastric tube, but the gold standard is still today to measure it via the bladder. You don't even need a device to do so. You can just simply do it by having some centimeters and looking at it. However, we have learned that the urinary bladder is quite an effective tool, and I don't have the time to go in all the different techniques that have been described for such a simple thing. However, there are many available using the urinary bladder pressure as an estimator for the intra-abdominal pressure. There have been developed some new devices which allow you simply by switching a knob or turning this device around to switch from urine flow to measurement. So there is a huge development. Technically spoken, there have been a development of balloon-based measurements like the Spiegelberg probe, which is a probe that takes up or picks up directly the intergastrial pressure. And there have been other methods using also the intergastrial pressure that are on the market and that are available. If we talk about balloons, you should be aware, and that's one of the reasons, and I go back to this very soon again, why we should probably go for a continuous measurement, because all the probes, this is not true for the Spiegelberg probe, because the Spiegelberg probe has a continuous control of the air content of the balloon. But for those balloons who have not such a control mechanism, you might get lost of your signal after some time because the balloon has lost its air. So having a continuous measurement or a discontinuous measurement with a balloon in the gastric space or in the gastric cavity means that you have to recheck from time to time that your balloon still contains air. Otherwise, you're going to lose the signal. This is very nice work from Juga Takala in this group, and he was comparing, as you can see here, intraperitoneal versus intragastric, intraperitoneal versus urinary bladder, intraperitoneal versus vena cava inferior. This was made in a pig experiment, and they were just putting 7 kilograms of weight onto the abdomen of the pigs. And as you can see, intraperitoneal and urinary bladder have a close relationship. And in this case, for the intraperitoneal measurement, there was used also a balloon, but maybe the most effective and most precise method to measure intra-abdominally is to use a piezoelectric electrode. And as you can see, if you compare to the vena cava inferior, and this is one of the most important lessons from these studies, the vena cava inferior tends to overestimate the intra-abdominal pressure and has the weakest correlation between all the other measurements that have been made. This study has also an additional very interesting aspect because they were looking at the combination of an increased positive and expiratory pressure. Increase in that case means an increase of 6 centimeters of water in PEEP and intra-abdominal pressure. And as you can see, there was a difference in urinary bladder pressure as well in the vena cava inferior pressure and so on. However, the increase in PEEP didn't change very much if the abdominal pressure was increased before in the measurements that have been made, saying going up with the PEEP to a level of 6 does not very much influence the pressure that can be measured independent from the method in the abdominal cavity. Does the position of the person in which you are measuring the abdominal pressure play a role? Of course, it plays a role. This is our data from Manu Malbrain, who is probably one of those people who has been taken most interest in the abdominal pressure. And as you can see, it's obviously position dependent, the abdominal pressure you measure, and there has also been by Cheatham in his group in 2009 a study where they were comparing all measurements and an IAP in supine, IAP 15 degrees head up and IAP 30 degrees with and without increased intra-abdominal pressure. In the conclusion were head of bed elevation results in clinically significant increases in measured IAP until the implication and clinical accuracy is tested. We don't know exactly. The thing is, well, that's something you all can imagine. So we measure in strict supine position. However, if you are doing right, at least as those of you who would put every patient as long as possible in 30 degrees up body position, well, what does it make, what sense does it make to have a measurement in supine? If the patient, if you are lucky, 23 hours a day in 30 degrees elevated body. So it's a very open question, and I think you should measure the pressure that really is be measurable and is those that is effective in the time when the patient is in his position. However, the rules are, if you measure, you measure in strict supine. So to make a long story short, my personal belief, if you want to cite to measure intra-abdominal pressure, you should go for continuous measurement. It's not a snapshot, it's a higher precision, it's automaticized, higher reproducibility. You have a lower inter or intrapersonal variability. You might earlier identify changes and you have an earlier chance to intervene. My ideal probe would look like this one. So 2 balloons, one to measure the intraesophageal pressure, the other one to measure the intra-abdominal pressure, and additionally they have some electrode rings to get an EMG signal. This would be, in my opinion, the ideal tool. Everything you can get out of such a stupid gastric tube to have these combined in one thing. However, the most important pitfall, and this is something to consider increased abdominal pressure as an own disease. This is something, well, everyone talks about intra-abdominal pressure. Intra-abdominal pressure is a symptom. It's not an own disease. So it's much more worthwhile to think why is the intra-abdominal pressure increased than to consider what to do to get 2 centimeters of mercury up or down in the intra-abdominal pressure. So that's, in my opinion, because, you know, we have a World Confederation of Intra-Abdominal Pressure. Maybe we should set up a World Confederation for fever or something like that. It's the same as fever. It's just a symptom, nothing else. So, but nevertheless, it influences many things. So, and we skip all these things and just concentrate on one thing, and that's in the effects, because this is my task on the pulmonary system. So it increases intrathoracic pressure, peak inspiratory pressure, mean airway pressure. It decreases dynamic compliance or increases, as you say, elastance. It diminishes the PaO2, it increases PCO2, increases shunt volume and dead space ventilation. And this occurs already at very, very low intra-abdominal pressures. This is a study from Ms. Anderson, published in Anesthesiology, and this was during gallbladder operation. And as you can see, they used an intra-abdominal pressure for laparoscopic surgical procedure of 11 to 13, and to make a long story short, they even find having these low pressures an increase in atelectasis formation in these lungs. These procedures took up to 1 hour. And as you can see, it was not only in those areas close to the diaphragm, but also in the upper lobes of the lung. And this is something that I put together with Paolo Pelosi. So we were looking for chest wall elastance and the relation to abdominal pressure in normal subjects, and as you can see, obese subjects and surgical subjects. Those who have a real problem in the abdominal cavity tend to have the highest chest wall elastance. And that's what Antonio was going to explain you. This is work from Luciano showing the compartimentalization of the elastance of the lungs and the chest wall. So this is normal. Normally, the lung has a higher elastance than the chest wall. However, as soon as you influence the intra-abdominal pressure or the elastance of the chest wall by putting a weight on it or by increasing the abdominal mass, you get an increase in the chest wall elastance. If you do so, your transpulmonary pressure decreases, which is the driving pressure for opening up the alveoli. That's the simple story. Or to keep the alveoli open at the end of expiration. That's the driving force. So, and this was the study that was mentioned by Antonio Pesenti. This is the Talmor study, and I just give you the values now. This is transpulmonary and expiratory pressure. As you can see, it was -2 in the conventional group, and it was close to 0 in the group of those patients that have been treated with the esophageal pressure. And interestingly, if you compare, this ended up in one group with a PEEP of 17 and in the other one of 10. So there's another reason to think carefully about intra-abdominal pressure. We know that fluid clearance from the thoracic cavity and from the lungs is impaired, which has nicely been shown by War and Matai, is clearly impaired by patients having LI or RDS. And of course, there's many things that can be and will be tried to be influenced. Extremely natrium channels, potassium channels, which play a role in fluid clearance from the lungs. However, one of the most important things is up here, increased lymphatic drainage. So lymphatic drainage is the way how the lungs can get rid of extra water. And there are 3 ways how the lungs can get rid of water: via the lung hilus, via the pleural space, or via the abdomen. And be aware, and that's just my last idea of why it's important to discuss intra-abdominal pressure. One of the roots is the intra-abdominal pressure. And this is a study we performed, Paolo Pelosi and Luciano and I, a few years ago. And as you can see, we applied the same PIV, so PIV of 0, 20, and 40. And the resulting, because the increase of the intra-abdominal pressure, the resulting transpulmonary pressure, even at 40, was so small that there was still nearly no recruitment at an airway pressure of 40 in those lungs having an intra-abdominal pressure of 20, which is the proof that it plays an important role with regard to the capability to open up alveolar or to keep these alveolar open. And interestingly, we made in this study the observation that there is an increase in excess tissue mass which goes up all the lungs, from the parts close to the diaphragm up to the parts up to the jugular space. So it's not only close to the diaphragm, but it is finally extended to the whole lung. So, and what we learned from this study increases the intra-abdominal pressure, increases chest wall elastance. It reduces, as I've tried to show you, the transpulmonary pressure. It increases or it causes a massive increase of excess tissue water in what we would call edema. And what was an interesting observation in this study, these changes happened very fast, within 20 or 25 minutes. So again, this is a study from Kees Frostel. It's very nice. It's, as you can see, it's 1987. And he said thoracic lymph flow was found to be 6.1 before and 29 plus minus 4.6 after induction of lung damage. So clearly demonstrating lymphatic drainage is one of the ways how you can get rid of excess tissue water. And this was reduced or depressed before and after damage when a positive and expiratory pressure was applied. The same will happen if you increase intra-abdominal pressure. And then he said spontaneous breathing compared to mechanical ventilation increased again the thoracic lymph flow, even when the PEEP was applied. Well, this is work from Dietrich Hensler. And he did an animal experiment with a long time of increased intra-abdominal pressure, made a release and some measurements after the release. And I don't have the time to go into details, but he was using a period of 9 hours of 30 centimeters of water intra-abdominal pressure. And he made the comparison with B-level mechanical ventilation with spontaneous breathing and without spontaneous breathing. And as we would expect, probably, he found out and was able to show there was an improvement in mean arterial pressure. If you allow spontaneous breathing attempt, there was a better, better VT, and so on. So all the respiratory parameters and the gas exchange parameters we were aiming in seems to be much better if, during a phase of increased intra-abdominal pressure, spontaneous breathing attempts were allowed. And this closes the circle to the talk of Antonio before. However, if you look at the lung damage was tremendously aggravated in those animals that had the chance to breathe spontaneously, especially in the regions close to the diaphragm, but even so in those regions far away from the diaphragm. And one of the reasons was high respiratory drive in these animals and, of course, a high chance of damage and fighting with the ventilator in a sense, not that they fight it in a way that they've struggled against it, but they put high negative and high positive pressures. So my summary about the abdominal pressure and what it, to my opinion, implies for monitoring. Increased intra-abdominal pressure reduces the transpulmonary pressure as the driving force for alveolar opening and avoidance of collapsing. And maybe the last one is even more important, to avoid an expiratory collapse. ERP is a continuously acting force, while direct transdiaphragmatic pressures and indirect transpulmonary pressures effect on respiratory mechanics and pulmonary function. So if we measure it, we have to consider what for would we like to monitor it, and can we draw any conclusions to allow us to change the settings. Short-term recruitment maneuvers, if we just think to apply, let's say, whatever kind of recruitment maneuver, 40-40, which is one of the most famous because everyone has just picked it up and wrote it in his article because it has been once published. But as you know, there is no rationale behind 40-40. But even if you use 40 for 40 seconds, you can expect having a high intra-abdominal pressure that the effect will be close to zero. And finally, and last not least, consistent recruitment or keeping lungs really open in patients with increased intra-abdominal pressure certainly needs a higher PEEP than in any normal subject. Thank you very much for that.